everyone, just a quick courtesy message to let you know that the first half of the podcast is a yarn between Blake and myself. If you want to get straight to the juicy stuff with Dr Rich Willy, jump to about 26 minutes and you can go from there.
Welcome back, Sports Medicine Project people. Hope you're all, again, had a lovely weekend and a lovely week. And for the people that went back to work last week, I hope you're feeling back into the swing of things. And then people starting, hopefully if you're listening to this, which will be the Monday, I hope you're going to have a cracking week and really get stuck into it. I'm here with my co-host, Kelly Kortic, 2040 Park Run 5K PB. Kelly, how you going? Welcome.
Thank you. I'm good. How are you? I'm actually really good today.
Yeah, you've been good today?
Yeah, I am. I'm feeling in the zone.
Yeah, we had a good day, didn't we? Went for a 2-hour long run this morning. Took it easy.
Today has been a bit of a flow state, I might even say.
Yeah, you and I have been working since about 10 o'clock. I've been doing some research. You've been doing some content, and learning about females in sport. Yeah, and then we're about to go play some bat-ball.
That's got to be a record for me. I'm usually like an hour in, out, done. But today, nah.
You know why? Because you went easy on the long run. That's why.
That zone 2.
Trusted the science. Kelly and I have been, well, probably myself particularly, have just been doing the last 6 weeks, purely 90% of my training week has been in zone 2, and it's been life-changing. It's been good.
I'd say mine, probably not
when you
90%. I'd say maybe like 70% of my training has been in about zone 2.
Yeah, and I'm excited because next weekend, and I can't pronounce his last name, but we're having Adam on the podcast, who it's Runners One, isn't it?
It's Run Strong?
Run Strong head coach down in Adelaide and the coach of Jess Stenson, Commonwealth Games winner. And we're going to talk a lot about running. We're going to do a bit of a series part. I just want to know, or have someone explain that knows what they're talking about, running physiology, aerobic system, anaerobic system, how to train them, maybe an example of some sessions, that kind of thing, and then obviously talk about all the other wonderful things that come along with being a knowledgeable coach. Yeah, it'll be good.
Looking forward to that.
Well, shall we get stuck into
We've been on a bit of a runner's roll lately. We've had all running podcasts lately, which is great.
What was the last one?
Reggie.
Oh yeah, Reggie.
And then
yeah, that was
got
really
two podcasts
popular.
in a row for Rich Willy.
Yeah.
And then...
I guess it is running, but it's bone stress injuries in general.
Yeah, but that's pretty much running.
Yeah, I guess...
In the context of what we're talking about, we're talking about it in running.
I guess that's the most common. Yeah, I mean, but then again, in saying that, we see clinically, and it's the typical archetype is an older female who end up with like a little lateral fifth met stressy or a second met stressy.
An older female, you think, is the typical archetype of a bone stress injury?
I'm just saying, we see them as well.
Oh, yeah.
Yeah, like not to say it's just runners, like the other people, I guess the other type in the population can be, and the example would be an older female with it seems to be a fifth. That would still
be in a walker or a runner in most cases, I would say.
No, not the cases that we see. Oh, definitely in a walker, but not a runner. So usually there's some other combination of whether it be like a higher BMI or osteoporosis or some other chronic condition, but I've seen a few of them lately. Okay. Definitely nowhere near as much as BSIs like tibias and people in runners.
I wonder if the management's different. Do you think the management's different when they're not a runner?
I don't know. I guess it would. Your education would definitely be different.
Like if they're already not running and they're developing a bone stress injury, how much deloading do you have to do?
Yeah.
Or is it about loading them even more to try and strengthen their bones? I don't know. Do you know what I mean?
Yeah, the management would be different because I think the contributing factors would be different because it's very likely. And like over the weekend, we've been talking and doing some research at the moment around pain and injury and looking at the risk factors for that. Like the typical person that has pain or pathology, they usually have comorbidities like osteoporosis, high BMI, high blood pressure. There's lots of other factors that influence it. Whereas typically with a runner, it's training error or nutrition or those two generally. Yeah, that's a good one.
Bit off topic. Well,
anyway,
I guess not, but...
Yeah, nothing's off topic when on the Sports Medicine Project. Sounds like an ad. Let's get stuck in. What do you want to... Do you want to start with your highs and lows? Oh, yeah. Sure. We probably should introduce... Well, today's episode is part 1 with Dr. Rich Willy.
Yeah, you guys are going to love it. We loved it. We got off this chat and we were like instantly calling and messaging each other being like, that was freaking awesome, because we were on Zoom, Blake and I. So yeah, so much good information, so many amazing clinical pearls and takeaways. It's, how long's it been? Almost like 3 or 4 weeks since we recorded this podcast. And probably every day I've said to Blake, oh, remember that other thing that Rich said on the podcast? What are your thoughts on that?
Yeah.
So there's just so much good information to get out of this, and I'm really excited to hear what you guys all think.
Yeah, completely agree. I would, in my opinion, he is one of the voices I definitely trust in the whole world at the moment, talking about bone stress injuries in runners. And whether that be, I mean, he's involved in, it's like the perfect scenario. He's got a cracking online presence and he posts great content. Secondly, he also sees runners. He sees people with bone stress injuries. He understands the complexity of dealing with people. And then thirdly, he's doing research around it. They're like the 3 pillars.
Triple threat.
Probably not social media, but in my opinion, again, probably isn't right, but seeing
and
patients...
lots of experience.
Lots of experience is the other one, yeah. Seeing patients and doing research and having lots of experience, like that just... Yeah, I'm going to be hanging on every word you say.
I would also add, having done multiple courses before, so refining the delivery of the information so that it's incredibly digestible.
Yeah. Do you want to just jump straight to that and talk about our biggest takeaways?
Sure.
You want to go first or I'll go first? You go first.
I'll go first. My 2 biggest takeaways, and there were so many, so these are just the ones that popped off the top of my head, and I think one of them is the same one as yours. The difference between trabecular bone and cortical bone in their manifestation of bone stress injuries. Trabecular bone is more energy demanding, so you'll often see women, or more likely, but also men, who are going through relative energy deficiency in sport, ending up with a bone stress injury of trabecular bone. So that's the bones that are a bit more proximal. So your neck of femur, your sacrum,
yep.
Your pelvis, for example, compared to your cortical bone, which is potentially more going to be related to biomechanics, is what Rich Willy was saying. So I think we mentioned or touched on that a few episodes ago, but I wasn't entirely sure about why the trabecular bone tends to be more so affected than cortical bone when Rehabilitation is apparent, and it's because the trabecular bone is more energy demanding or energy hungry. So if you don't have the sufficient amount of nutrients, then it is going to be at risk of developing a bone stress injury.
Yeah, the fuel for bone turnover.
Yeah.
And a good example, like your metatarsals are more cortical bone, thicker, harder. Yeah, that was really interesting.
Yeah.
That got me thinking. And as you were saying, can definitely happen to both, but relative or Rehabilitation or LEA, low energy availability, is more common in females. So that's why, amongst other factors, I'm sure why he was predicting that bone stress injuries are more common.
Yeah.
Proximal bone stress injuries are more common in females. And
I guess in terms of clinical practice for us, that means if you're seeing a patient that has a bone stress injury of any of these areas, then we need to be even more aware of the fact that they really need to be in a good multidisciplinary team, including dietitian, sports doctor, which is pretty much a non-negotiable anyways, and potentially even an endocrinologist.
Yeah. We were talking about, I don't know if you remember, a couple of episodes ago, and I did end up doing a bit of a dive into it and found a little bit of research, but remember when we were talking about patients and gender differences for the clinical practitioner? So, if you and I were to deliver the same information to a female or a male, how that would be different based off, if you or I were a male or female. And I did find a little bit, it was based in the USA, about like physicians, if they're male or female, sometimes depending on It was to do with age and gender. So obviously there's some, I guess they're both related at the same time and which is which, but males tend to be seen as more trustworthy and more knowledgeable and have more education I guess it was in hospitals I were talking about physicians. And I was thinking when you just mentioned that, if I was to talk about someone in their 20s, 30s, talking with someone in their 20s, 30s or 40s, and I would never see someone with a femoral stressor or a sacrum stressor that I suspected, but for a young male practitioner, and I know I'm putting you on the spot, how would you recommend they approach that conversation in recommending that they see a dietitian?
I think what you would typically do would be explaining to them that, which you're going to do anyways, that lots of factors are going to influence a bone stress injury, and with these particular bone injury sites, there seems to be a larger factor coming from your energy or your diet, I guess you could say. Or nutritional intake or energy balance, whatever you want to word that as. However, I also don't feel as though we always need to be having that conversation, because we're definitely going to recommend them to see a sports doctor, and I think a sports doctor is generally going to be recommending a dietitian.
Do you think it's better if it comes from both though? And
yeah,
not
probably.
always. And like you said, we're not always one to have that conversation, but
and then
I would imagine
the other thing that I think, sorry, I just interrupted you.
That's all right.
You go.
If they're not, maybe they might not have access to a sports doctor, or they might just not want to see a sports doctor, and you've got a great dietitian who you can refer to. I just imagine that conversation would be hard. I know I struggle with it, definitely. I sometimes get around and I'm like, oh, and I don't deliver it with good straight tone that I would say talking about heel pain or something like that.
The other thing that I do when I'm having difficult conversations about injuries that have lots of factors is saying, we're ticking the box of load management, we're ticking the box of, appropriate diagnostics, we're ticking the box of cross-training. A really important box that we need to tick is reviewing your diet or your nutrition and making sure that that's not going to be influencing your recovery. We want you to be getting back to running as soon as possible. So if we can tick all of these boxes, then you're going to be on a far better track to return to running as soon as possible. So I think that's maybe a good way to explain it too.
Do you think this is right? One thing I've said following when I'll have this conversation is when perhaps that it is a factor playing into this bone stress injury, and then I will follow up and say, even if we do get all the strength training, the resistance training right, we get your footwear right, we get your understanding of what's going on right, and we also get your training right, even if they are all right and everything's going really well, if you're not fueling correctly, it's quite the possibility that those factors won't have any influence on you getting better. And that can sometimes be like, even though if doing all this great stuff, it might not actually work unless I get this one factor addressed, which I would think, I'm sure that might not be true in some cases, but I would also think, and based off, is it Rennie McGregor? I remember her saying that you can get everything right, but if the fueling's not right, the bone's not going to turn over. So that's one thing I have been saying. What do you think? Right or wrong?
Yeah, I agree. And that's another thing that Rich said.
You agree? Nice.
Well, that's another thing that Rich said as well.
I said it.
Wait, listen. He said that when trabecular bone is affected in bone stress injuries, you need to be also very aware of how much cross-training they're doing. So even if they're doing lots of swimming, lots of cycling, they still might be churning through too much energy to actually allow the bone to heal. So if they're not fueling appropriately and they're cross-training like mad, then that's a problem. So maybe you need to be pulling back from some of that cross-training in those particular injuries as well. Why are you laughing at me?
Well, I was thinking we might as well just stop the podcast because I'm going to say a couple of good ones and I'm like, that's basically, we're just repeating what he said.
Maybe
I would just end it.
So this has been us over the last 6 weeks. It's just
it's great. Good,
reflecting on this podcast. Maybe we should stop talking about it and just make everyone listen to it.
I do want to say one more. And the way that we're saying it is the way that we would say it to people and patients. But that's the way that he told us, which you'll get it out of this podcast. It's just the information is so digestible. Yeah. What I got from it was plantar flexor forces, internal plantar flexor forces, are one of the big factors to be thinking about with bone stress injuries. So as we've talked about previously on the podcast.
With tibia bone stress injuries.
Sorry, yeah, with tibial bone stress injuries, which are the most common, easily the most common ones that I see, and I would assume you as well. So faster running, you're going to be increasing the plantar flexor forces, and we know that faster running can have an impact on healing rates, rehab, and also contributes to why they occur, but also running uphill. So if you're running up a hill, you're very likely going to be on your midfoot, on your toes, and you're going to be doing basically an isometric calf raise, and that's going to be putting more internal forces through the tibia, which can then inherently either impact your return to running or impact on the risk of having a tibial stress injury. So just thinking in my head now, when I'm programming rehab, I'm just like, which is always what we've said, you would need to make the plantar flexor forces really high if we want to get the bone strong, but also not too high in the sense of if we're doing too much in the gym, it's going to impact on how much fast running we're trying to do. So it's trying to balance those both. I thought that was cool. So
do you think it's the force or the volume?
I think it's the force, because he was saying it's the force, because how heavy or how much plantar flexor force pulls the tibia posteriorly. So he said, and I'm sure I'm going to say this now and I'm probably going to get it mixed up, but he was saying you have anterior shear force on the front of the tibia that also increases the bone, and then also when the plantar flexors pull the tibia back, you get posterior bending forces, and that's what inherently makes the bone stronger because it responds to that stimuli. So it needs to be heavy and challenging, which was what I've always done in the gym, is like, my bone stress injury patients that I see, it's typically 4 to 5 sets of usually between 5 to 8 reps, and it's heavy and challenging. And I say, you've got to finish the set, with what we call reps in reserve, maybe 2 or 3 reps in reserve. Yeah. Or sometimes I'll say, if someone said you could do, here's $1 million, if you can do 1 more rep, you could just do it. I'll leave it at that because we've probably talked a lot about his injuries. Any highs and lows? I've got a couple of things to chat about, but you got any highs and lows?
Yeah, I do. My low was Christmas and New Year's buggered me. Proper buggered me this week. I feel like I do feel as though it impacted my patient interactions a little bit because I was feeling real fatigued all week and just sleeping so much. Like, I was getting home from work at 7 o'clock and falling asleep on the lounge, which isn't a bad thing, but I was just buggered. Yeah. And that's, I guess it's a pro because Christmas and New Year's was a lot of fun, but a con because, man, I just was tired.
Yeah, it takes it out of you having, you might have some people between 10 to 20 interactions with different people with different problems, and you've got to be on. I remember when I first started as a new grad, a senior physio said one of the things that she thought was the marker of a good practitioner is regardless of how tired you are and how you feel, which will always be up and down, you can always be on for your patients. And I didn't really understand it until now, because after those times you're buggered, but you've got to be on for those people because they shouldn't have less care or less optimal care because of how you feel. But then also you're a human. It's funny
actually you say that too, because this week I was pretty buggered, and I could feel like I was trying to pull up all this energy with patients. I felt like my social battery was about 0. So I was trying to pull up all this energy with patients, but then my energy around my colleagues was terrible. And on Friday, Joe was like, "Are you okay?" And I was like, "I'm just pretty buggered, hey."
Fine. Yeah, it's a draining profession, definitely, but incredibly rewarding.
Well, can be. Not always, just on those sorts of weeks, you've got to put yourself to the bottom and put your patients first, and it can be hard.
Yeah, and then you'll have those people, and that's going to be one of my highs, you have those people that you see, which I definitely think happens more as you get more into the profession or years under your belt, but you have those patients where they will mention to you, I remember what it was like 6 months ago, or remember how it was 3 months ago, and you think, wow, you couldn't even do a calf raise, or you're hobbling in so much pain, and you and I work together, and now you're doing the things that we love, and I don't have to see you for 12 months, and it's just incredible. Or someone gets back to running a marathon, or some little boy can play cricket, or playing the gala day on the weekend.
Yeah,
good fun.
That's great. That's great.
Anything else? Well, that's all.
That was my low. My high was today after our long run, there was an event at the skate park. So we got our coffees and we walked over, and there was these young girls. They were under 9, the first group that we saw. ripping it up on the skate park, and they were just little weapons. They were so cool, and it just made me so happy because I just had a little reflection point that I'd imagine, 20 years ago, maybe even 10 years ago, there's probably a very small chance that there were many females skateboarding, let alone enough to be able to enter into a competition. And under nines, like, they were such small little humans, and they were incredible. And so we just sat there and watched them for about 30 minutes, and it just made me really proud of society having, come to the point that we are with women's sport. Still a really long way to go, but I think that there's progress, and that was me realizing and recognizing where the progress is, and I was really happy about it.
Yeah, I agree. One thing that really, really bugs me about people's perception of women's sport, and I'm not going to lie, it's typically comes from older men, is on social media. Anytime there is any post about or promoting women's sport, or saying that something comes out about how they're expanding the competition and things are going really well and it's great they're getting paid more, or they want to get paid more, there is always these ridiculous, arbitrary comments from older men saying, if they just get more bums on seat, or if they play as good as the men, or if they were as interesting as the men. And it's just horrible to see. It's just ridiculous. I don't know how they could possibly think that one is going to make anything better, or the impact that could have someone reading that, or a female that plays sport reading that. It's disgusting. It really is. That's one thing that I'm black and white on. It doesn't get anywhere.
I agree. I've got a good social media post coming on that this week.
You do. All right, should I start with my highs and lows?
You go.
Yeah, my high this week was and I'm going to do a post about this week, a lovely lady who I've been seeing now about 6 months with a unilateral stage 1 to stage 2 adult acquired flat foot. So initially saw this person, was referred by a physio. They tried some stuff, great pickup by the physio, could see definite unilateral deformity. It had progressed a little bit over the year, and sent this person to me for orthotics, which was great. Now, this is one of the cases where orthotics can really change people's life, and I'm happy to go on the record to say that when there is this deformity, there's not a likely chance of surgery, but without orthotics and strengthening, the condition can gradually get worse and become more deformed and more long-term consequences. And probably with all those things, it can still progress as well. But yeah, saw this person on Friday. We'd gone with some orthotics, we'd gone with some strength and conditioning, and things were going really well. So she was back doing her step class at the gym, which was awesome. And then in the gym on Friday, we were hopping and jumping and doing a single leg calf raise. And we were talking about 6 months ago when I very first saw her, we weren't able to do any of that. We weren't able to do a calf raise, definitely weren't able to hop or pulse or use a tendon with that high energy storage. And it was really great to see. And good footwear. We'd gone with some orthotics, we'd looked at some strength and conditioning, and all those things in combination just worked incredibly well. Got young kids, partner, they like to be active, and it was great. And it really, trying to this year, I'm going to reflect on those patients, because that, I guess, makes me more engaged and really makes me want to learn and be a better clinician, to have more of those experiences. And it was great. And then I'm not seeing this person for 12 months. And I love that. I love sitting there and saying, great, things are going well.
What's the point of seeing her in 12 months? Do you think is there a purpose to a 12-month follow-up, or is it?
Yeah, to check how the orthotics going.
Okay.
Yeah, so.
Because I feel like if I followed up with a patient in 12 months, I'd be like, it's just too much. Do you know what I mean? Like, I don't know. Yeah.
And there wasn't much more. Like, she was doing everything she wanted to do. I'd given her some stuff. I was like, great. All I want you to do is twice a week, do some hopping, do some single leg calf raises, and all your activity plus your step class. But she will be a person, and if anyone does disagree with this, I would love to have some dialogue with this typical case. And not to say that it's very severe, but with an adult acquired flat foot, generally orthotics are more longer term, because people can function better with them. And the deformity is not going to change. If anything, it's only going to get worse. I want to check the orthotic, very likely not replace it, maybe just replace the cover, make it a little bit more controlling. If she's going really well, and we talked about that, I was like, great, if you find some time, she's been wearing thongs more, I was like, great, if you can wear your thongs more and not rely so much on the orthotic, that's awesome. But the reality is, and from experience, people generally do need them a little bit longer term, but doesn't always mean that you will, which is great. Yeah, but anyway, cool. We were sitting there and she was like, oh, great, see you in 12 months. And I was like, oh, it's awesome. The longer apart that I see you, the better you're going. In 12 months, you can't get much longer than that, which was cool.
That's cool.
Yeah, so my low as well was my pain education knowledge. So I had a patient over the last couple of months where we'd been dealing with some chronic foot pain that had been going on for a while, and we got some improvement, but there was definitely other psychosocial influences on this person's pain, and I really thought that we could work through them and address them and get a better understanding of what was happening. And I really struggled. So I saw this person a couple of times who did some other things, but just referred her on to someone with a lot more knowledge and understanding than myself. And it just made me reflect and think that I really need to get a better understanding of pain and how I explain and talk about that with my patients.
I also think it's good to refer them on to, the person you've identified would manage that better though. You don't have to be that person to everyone.
That is true. I just thought I could have got a little bit further. And you're right, I do refer on quite a lot. I just thought, I was like, it's good practice, and I can't always refer out, and not all the time other people are going to want to see someone else. But I just thought I could have got them a little bit further, but I couldn't. But yeah, that was about all. So highs and lows done. Anything else to leave our lovely listeners with? We didn't even get through everything we wanted to talk about.
Yeah, we've been rambling a lot though. So let's get into the podcast with Dr. Rich Willy.
Yes, enjoy guys.
Good afternoon or good morning, and welcome to another episode of the Sports Medicine Project. We have a special guest that Blake and I are both super excited to introduce. We have Rich Willy from Montana Running Lab. Welcome.
Oh, thank you. It's wonderful to be here, and I certainly appreciate this opportunity. And so it's going to be great to talk the next hour or so about bone health and whatever else comes up.
Yes, which I'm sure there will be a lot that comes up, which always happens with these podcasts. But for the listeners, Rich, what do you do currently, and what kind of led you along the pathway to become, where you are now?
Well, I'm my current title is associate professor at the University of Montana. I'm in our School of Physical Therapy here, and so I teach about 35-40% of my time, and I do 50% research and then some committee work after that. So as far as research, I tend to focus on runners and also military relevant questions. So I get some Department of Defense funding here. We study things like risk of bone stress injuries, risk of knee injuries, and we look at sex differences also, why males get certain injuries versus females. So clinically, I still treat. I treat maybe 1 to 4 hours a week, which is really nice, and it's something that is very fulfilling for me. And I think if I didn't continue doing that, I think I would lose probably a little bit of focus on my teaching as well as research. So I've been a PT since 1999. I came out and I first started off actually doing more occupational health. So I started off working in factories and so forth. So which is actually a really nice way to kind of get started. It wasn't that I wanted to do that. It's just that there weren't that many PT jobs available at the time that were in sports medicine. So I started off doing that. And I actually kind of really grew to like it a lot. I think there are a lot of really nice parallels between runners and people who have occupational health injuries. So in other words, like someone who's a steel worker, they don't say that they go and work at a steel plant. It's kind of like runners. Runners don't say that they're someone who runs, typically call themselves a runner. So if someone who's working in a steel factory gets hurt, they end up losing part of their sense of self, which is very much the same as runners when they can't run. And so for me, I kind of gradually started working more toward a sports medicine type setting. And so I did that for several years. And then after 8 years as a PT, went back and got my PhD in biomechanics and movement sciences from the University of Delaware. And so I've started that in 2007 and I finished in 2011. And so I've been a faculty member kind of ever since, doing research and kind of doing the same thing that I'm doing now. So yeah, it's good. So I've been a PT now for, I guess, 23 years, which is a little bit hard to believe, but
Wow.
it's gone kind of quick, but it's been a wonderful career, and I really couldn't ask for anything else. I think there isn't really a part of my job that I don't really, that is not something, all those parts of my job, I very much look forward to every day. So it's a really great job.
Yeah, that's incredible. I mean, you've been busy the last several years by the sounds of it.
Oh, thanks. Yeah, thanks. Yeah, I was for a couple of years, I was our department chair. And that was a little bit more into the management side from what I probably see myself doing the rest of my career, but it was a nice opportunity to see that side of academia. Had to drop back on some research stuff. So I'm really looking forward to kind of getting back up to the level that I like doing as far as from a productivity standpoint. But yeah, I appreciate that. It's great. For me, I think it's awesome. I get paid to think and get paid to, ask questions that I think are certainly cool and get to write papers on it. So it's a really great career.
Yeah, I've got to admit, and thank you so much for like your Instagram page and your research as well. But I think for most of the listeners, especially younger practitioners who follow Montana Running Lab on Instagram, some of the content and the synthesis of the research you put out it really is incredible and so interesting to see. And it has translation to my clinical practice, and I'm sure Kelly's as well. So yeah, I've got to say thank you for that, definitely.
Oh yeah, thanks. No, it's a lot of fun. I mean, we do it basically because, well, Instagram is a funny place. I mean, anybody could put anything up, and I'm guessing that, you're running into the same thing that we were running into, which is that a lot of runners and also clinicians were, getting a lot of information from Instagram. And it seemed like there was a bit of a void there as far as like evidence-based recommendations and synthesis of multiple papers. And that's what we've tried to do. We've tried to make it somewhat digestible, something that is not overly complex as far as like multiple pages on Instagram. So yeah, thanks for that. I really appreciate it. Sounds like it's hitting its mark, and it is a lot of fun to do it. So I really enjoyed it. It's not something that, obviously Instagram is not something, unless you've got like 2 million followers, you're going to make any money off of doing it. So it's more of a fun thing to do than anything.
Yeah,
for sure.
And we'll get stuck in.
Yeah, so first question off the bat, I guess we better sort of start at the beginning. So the pathophysiology of bone stress injuries, can we briefly sort of touch on that for the listeners?
Yeah, definitely. Well, we don't really understand how bone stress injuries occur. We have a pretty good idea. I think that a lot of researchers who are much more basic than I am, meaning they use animal models often and we do a lot of imaging, are trying to figure this out. But excuse me. But essentially what we're looking at a mismatch in the rate that new bone is being laid down relative to the amount that bone is being broken down. And so it's an accumulation of bone microdamage. And what happens is that we'll start doing a lot of loading, and bone is naturally turning over on all of us. When you start loading a lot, bone microdamage starts to accumulate at a more rapid rate. And then what happens after a period of time, we have these bone cells that are called osteoclasts that will kind of work their way in and start removing some of this bone microdamage. There's a lag between when those bone cells come in and when osteoblasts arrive, which are the bone cells that are going to lay down new bone. And so in that time period, there ends up being about a 3 to 4 week period where things seem like they're going pretty good, but then bone microdamage starts to accumulate. And it's not really until that fourth week when the osteoblasts start laying down new bone. And so usually around the 3rd to 4th week is when bone is at its weakest. And that's when most bone stress injuries start to occur.
You're right.
Sorry about that. Excuse me. So anyway, so that's kind of when bone stress injuries start to occur. It starts to first show up as some accumulation of bone marrow edema. We might start getting some cortical bone disruption. It's not until we start seeing cortical bone disruption that's apparent on a radiograph. So MRI will start to show bone marrow edema a little bit earlier, and that's one of the reasons why MRI is a better imaging tool for most bone stress injuries. So yeah, bone stress injuries, I think that's one of the things that I think people tend to make the mistake about, is when it comes to equating the workload that they're doing in a given week with like how they're doing. It's not really until you're 3-4 weeks down the road that you can really tell how someone has done with the amount of workload that they've been doing. And so like after the holidays, which are, upon us, a lot of people will embark on fitness programs and so forth, and bone stress injuries will really start showing up around the first week of February or so.
Yeah. Yeah, that makes sense.
Sorry. Is there any way to identify any sort of changes in that sort of 3-week period? So like when there is that lag, is there anything that people could potentially be looking out for, do you think?
Ooh, that's a great question. I mean, I think that would be the $1 million research question, is if you can stop a bone stress injury while it's in its early stages. Clinically, there doesn't really seem to be anything. And there's been some work looking at some different like bone biomarkers that the military is looking at, so they can, track how people are responding to loads. But there really isn't a really good tool for this. The best predictor, of course, is if you've had a bone stress injury in the past. And so if you've had a prior bone stress injury, you have a 600% increased risk of having a subsequent one.
Wow.
So, and that's for females. Males, it's actually a little bit higher. It's a 700% increased risk. So if that sounds like you, when you do some sort of training load error, the injury that you're going to get is probably going to be another bone stress injury, and it might be at a different site. So if you've had a tibial bone stress injury in the past, it doesn't necessarily guarantee that you're going to get a bone stress injury there again. It might be somewhere else in your fibula or metatarsal or what have you. But yeah, so I think that that's probably the number one predictor. We know that there are some other things that contribute to risk as well that I think are really important to watch out for. Some of those might be loss of sleep. So we know that athletes who are not getting at least 6.5 hours of sleep or so have about a 20 to 30% increased risk of developing a bone stress injury during a large training spike. And the other ones that I think would be important risk factors would be, if the athlete didn't play ball sports when they were growing up, particularly between the ages of 9 and 13. That seems to be a really kind of crucial time for building bone diameter, which is a real strong predictor of bone strength later on in life. If that sounds like you, that also, if you've done that, that's great. It's really hard to go back in time and change some of these bone stress injury risk factors. So I think those would be some important ones. And of course, if for females, if there was delayed menarche or any sort of menstrual disruption as a teenager, even though you might be in your 20s or even 30s, that's a really crucial time for having optimal hormonal health. And when it comes to laying down new bone. And so if that sounds like you when you're in your teens, that's unfortunately going to increase your risk of developing a bone stress injury later on in life as well.
Wow.
As far as like looking at early indicators, I don't know. I would have to say that bone injuries, this accumulation of bone damage kind of lags behind other injuries. So if you've been experiencing a lot of muscle soreness because muscle is going to be a little bit more responsive to loading, I think that would be someone that I would probably pay very close attention to. So if you're experiencing a lot of delayed onset muscle soreness in the first couple of weeks, I think that's telling you that your muscular system is having a hard time keeping up with the amount of load that you're throwing at it. And muscle is attached to bone. And if the muscle is having a hard time, then I'm sure the bone is having a hard time too.
That's a good one. I like that.
Have we moved away, and I remember learning this at a university level, from like what we think are likely contributors, the muscle traction theory of the deep plantar flexors, and then also the bending forces on the tibia and the impact forces. Can you speak much to those kind of theories and if we've kind of moved away from them?
Yeah, I mean, every bone stress injury is different, or each bone stress injury site is a little bit different. And like, what are the contributing factors to those? I mean, about 40 to 50% of all bone stress injuries involve the posterior medial tibia. And so we know the most of that about that injury. And so it used to be thought that impact forces were a really large part of this. And this kind of really really got very popularized by the book Born to Run, and the whole barefoot running craze. Everybody was very concerned about impact forces, and at the time it kind of made some sense. But now that we're starting to understand like how to model bone forces a little bit better, it seems that the muscle forces are the biggest contributors to overall bone loads. And so when you think about a bone, there's an anterior portion of it and a posterior portion to it. And when you think about your tibia, your plantar flexors are very strong. And when they contract, they will bow that tibia posteriorly. And then we'll get a lot of traction force on the anterior aspect of your tibial shaft. You get strain there. You also get stress, which is basically the amount of force on a given surface area. That's also going to occur in the posterior aspect as well. And so we tend to get more bone stress injuries in the posterior aspect, but the ones that are on the anterior aspect of our tibia are the ones that are much more serious. Those are these high risk bone stress injuries that are going to take a very long time to heal. So I think that we used to think that it was this muscle traction that also contributed, but it's really not so much that. It's more like the muscle is twisting and bending the bone, and that's what's causing a lot of stress throughout the bone. And so with that being said, when we're looking at like how can we control bone stress, it used to be that it was impacts, but now it's much more so looking at like muscle forces. And a good rule of thumb, for instance, in the lower leg is that anything that increases your plantar flexor forces, so soleus or gastrocnemius forces, increases tibial bone stress. And not only does it increase tibial bone stress, it also will increase metatarsal bone stress as well, too. So for instance, like if you run in a low drop shoe, we know that increases your demands on your plantar flexors, and that's also going to increase tibial bone stress, but it'll also increase the bending torques on your metatarsals, for instance. And so another way to look at that too is if you want to reduce your bone stress, you just control the amount of plantar flexor forces that you're experiencing in your lower legs, and that's going to reduce your overall bone loads.
Yeah. Is that, and talking to that, how, and I had two medial tibial stress syndrome patients this morning and 3 yesterday, and explaining to them, how do we build bone resiliency? Like what ways and metrics and clinicians and athletes think about? Like my understanding is it's heavy resistance and plyometrics and just getting the dosage right. What do you have to say about that?
Yeah, I mean, we know that, load is not good or bad, and the load can be very helpful. The load can be very helpful. It can also cause injury, and like too much of it causes injury, but the right amount will make something stronger. And so bone's the same, bone, behaves according to that law. And so when you look at it, if you're trying to increase bone health, the best thing to do is 20 to 40 repetitions of a very high magnitude load. And that load should exceed what you typically will experience during your activity of choice. So if you're a runner, the load that you're experiencing on your tibia should exceed that load that you would normally be experiencing during running. So when we run, our tibial bone force ends up being around 9 body weights of force, which sounds like a lot. And when you think about it, going back to the prior question, about 2.5 times our body weight is the vertical ground reaction force, and the rest of that, the remainder of 6.5 body weights is coming from your soleus and your plantar flexors. So if you want to make your tibia stronger, the way to do that is to do some sort of heavy resistance training that's going to be loading your plantar flexors, and you want to make sure that loading is not just heavy but also fast as well, because that's what's going to cause a lot of strain in the bone. And the bone strain is what kind of excites these osteoblasts that are going to lay down new bone. Plyometrics are even better because you can load the bone so much faster, and you can also get a lot higher forces on the bone as well, particularly if you're doing like even just a very, modest like drop jump from like a 30 centimeter box or something like that. When you do that, you're going to hit the ground. You're going to hit the ground with maybe 3.5 times your body weight. Your tibial bone forces are going to be up in the double digits, and you're going to be causing a lot of bending and twisting of the bone, and that's going to result in some sort of bone stimulus, and the bone's going to react and get stronger. It'll take some time for that to happen, but that's really the way to do it. What happens is that if you keep loading with a lot of repetitions, that's when the bone stops responding. The bone microdamage continues, and that's how you're going to get a bone stress injury. So there's really this very delicate dance that you want to have. where you're jumping some, and you're jumping with a lot of forces, or you're lifting with a lot of forces, and you're maybe only doing 40, maybe 50 repetitions at most, then you take a break, you don't load for 4 to 5 hours, and then maybe you go and do it again.
Yeah.
Another break, 4 to 5 hours, and do it again. And that would be the best, most optimal loading program that you can put yourself on. Most people can't do that. And so the other way to do it is just space it out over a couple of days, and you're still going to get some really nice changes in overall bone health.
That's great. I'm going to call those patients now and say, hey, you're doing the right thing. Don't stop.
Right.
Yeah, that's cool. That's cool. So when we're on the topic of, locations of bone stress injuries and sex differences as well, which we touched on previously, I saw a post recently that you put up about the differences in location between males and females of bone stress injuries, being trabecular bone perhaps more common in females, and cortical bone perhaps being more common in males due to the effects of Rehabilitation. Can we talk about that? Because this is something that I've been really thinking about quite a lot lately, and I'm really excited to hear your thoughts on it in length.
Yeah, so the tibia, whether you're male or female, is the most common site for bone stress injuries, followed by metatarsals. And so when you look at males, about 55% of all bone stress injuries are in the posterior medial tibia. For females, it ends up being around 35%. A quarter of all bone stress injuries are in the metatarsals, which with the second metatarsal being the most commonly affected. Once you get away from that, then things become a little bit more distributive in females. So females tend to have more femoral bone stress injuries. They tend to get many more sacral bone stress injuries, perhaps pelvic, and also lumbar bone stress injuries. We don't see that as much in males, and there are a couple of different reasons for that. But the big one being that the lumbar spine, the sacrum, is a much more of a trabecular-rich site, so you have much more trabecular bone. Trabecular bone is much more metabolically active, so it requires a lot more energy. And so because of that, it is more susceptible to Rehabilitation. Rehabilitation is much more common in female athletes than males, at least that's what we think. It's not that males don't get it, but females are a little bit more prone to that. So a good rule of thumb is the closer you're to the ground, the more biomechanics matter. The further you get away from the ground, the more that energy availability matters. So if you're treating someone with a femoral bone stress injury, particularly femoral neck, we used to think, okay, well, surely there's some biomechanics that are at play here. And there are some. For instance, in the military, for people who are shorter, who have smaller bones, who are often female, just happen to be, but they end up having to take a longer stride to keep stride with taller cadets, for instance, and that can result in a lot of extra bending forces on the femoral neck. But the femoral neck also has a lot of trabecular bone in it, and so with the exception of that one, like overstriding type biomechanic, if you see someone with a femoral neck bone stress injury, you should immediately start thinking relative energy deficiency in sport, and sacrum. Absolutely, I think if you have someone with a sacral bone stress injury, I think probably one of the last things you should probably be talking to them about is their biomechanics, and lumbar spine even more so. So if you see someone and they go off and they get and I've heard patients have come back, they've come to see me for like consults after they've seen other people. They'll bring in like a DEXA scan. They're like, oh, I'm only osteopenic in my lumbar spine, and my femoral neck, it looks okay. And when you look at the numbers, that's true. But because the lumbar spine has so much more trabecular bone than the femoral neck does, for instance, we start seeing the effects of Rehabilitation and these trabecular-rich bone sites. So the lumbar spine has much more trabecular bone than the femoral neck does, and that has much more trabecular bone than like the metatarsal shaft does. And so when you get down to the metatarsals, it's much more of a cortical bone type structure. There's not a lot of trabecular bone there, and cortical bone is not quite as susceptible to these like fluctuations and energy availability. And so we can typically get away with some periods of low energy availability with those bone sites, but you're not going to be able to get away with that with sites that are more proximal.
Yeah,
that's really interesting. I've often wondered, patients with
sacral stress fractures, how does it, you're loading your legs and there's such a large amount of force going through the lower leg. How does the sacrum end up with a stress fracture? So that makes a lot of sense. And I was quite curious as to by what mechanism that was, but you explained that really well, as the trabecular bone being more, energy hungry. And if you're not fueling appropriately, then that's certainly going to put you at risk of an injury in that area.
Yeah, exactly. And something else to think about too is that our pelvis forms a ring, and like we wear a wedding ring for a reason, because it's supposed to symbolize something that's very strong, right? And rings are very strong. Like our diaphysis on our bones there are rings. There's a cylinder, so it's very strong. But the way that works is that when you load one part of that ring, of that pelvic ring, it's going to distribute the load the whole way throughout the ring. And so if you're talking about your sacrum, the overall bone loads are not as much, but when you run, like the sacrum is getting loads with both foot strikes. And so it doesn't take a lot of load up there when someone is not repairing micro damage very well for them to start accumulating this micro damage and end up getting this bone stress injury. And unfortunately, they get missed for a long period of time. These more trabecular rich bone stress injuries, femoral neck BSIs, they get missed on average for 5 months.
Wow.
And that's 5 months of lost healing time. Sacrum, same deal. They often, PTs, when they see someone coming in with pain in that area, they often start thinking like an SI joint issue. And so it's happened multiple times in my career. I've seen someone who's been treated for SI joint dysfunction, but they actually have some sort of sacral bone stress injury that just has not been picked up yet.
Yeah, wow. Is it true bone health? And I think I heard this on Brad Beer's podcast, I think with Stuart Warden. Is it true that up to 75% of bone health is determined by someone's genetics? Like, is there a big genetic predisposition?
Yeah, absolutely. I mean, if you have, it's and genetic predisposition determines like your bone size. So some really early work from the late 90s from Kim Bonnell, they were looking at calf girth and also malleolar width. And of course, that's going to give you some idea of overall like bone size. And so, the larger, if you have two people that have bones that are equal size, or I'm sorry, of equal load or accepting equal loads, the person with the smaller bone, that bone is always going to break down first. So your genetics is what determines that. So yeah, I mean, genetics is really like when we're talking about, weight training, we're talking about sleep, we're talking about plyometrics. These are just things that are going to cause very, very small changes in overall bone health. Your genetics is what's going to really determine this. And of course, also what you were doing as a teenager and preteens. But after that, our ability to move that needle is certainly there, but it's not like this major thing that we're able to really affect, but we still can do it. And it's certainly well worth our time to do that as clinicians.
Yeah. Can you talk much to many of the other factors that contribute, or I guess other things that athletes and clinicians, depending on what kind of profession you're in as a clinician, can recommend to athletes and people, for example, there's a bit of research around vitamin D and supplements and medications and obviously nutrition. Is there anything that you've seen that works incredibly well, or that you recommend that clinicians can probably think about recommending with their patients?
Yeah, I mean, I think vitamin D is a really interesting one. There seems to be some relationship between vitamin D and certain bone stress injuries. So anterior cortex bone stress injuries seem to be a little bit more susceptible to vitamin D deficiencies. So there's that. I think that, I'm not a registered dietitian. I think that I think anybody who I think a lot of running is a very energy intensive sport. And I think that if you have any sort of dietary restriction, and that is whether it be, voluntary or involuntary. So if you're lactose intolerant, for instance, or you don't eat gluten, or whatever, you name it. Those are individuals, if you're running, it's a very energy intensive activity, and you really should probably get a consult from a registered dietitian just to check in and make sure that you're hitting all your macro and your micronutrients and your overall caloric demand of the activity. And of course, gluten makes a lot of sense, right? Because gluten is in a lot of carbohydrates. And so if you're, really picky about your carbohydrate consumption because of gluten, you're going to be much more prone to developing some sort of energy deficit. The other ones too, I think I think anybody who's on any sort of like, quote unquote diet. So like right now, like we hear a lot about paleo diets. There's been some really nice work that has shown that even brief periods of doing a high fat, low carb diet results in a rapid accumulation of bone microdamage. We see a big spike in bone biomarkers that is telling us that there's a lot of bone breakdown that's occurring, and the other biomarker that is signaling that new bone is being laid down doesn't seem to go up at the same rate as if someone is supplementing with carbohydrates. So I think that's a really important one. I think it's when I first came out with my PhD in 2011, I came out of this biomechanics lab. We were doing a lot of work with biomechanics, looking at tibial bone stress injuries. And so for me, I thought biomechanics was the main driving factor here, but more and more, I think it really has to do with energy availability that really matters the most. And so I think, and I can't emphasize that enough. I think like it's something that, clinicians they're maybe a little bit uncomfortable talking to someone about. And I think it's really important to make sure that you can kind of pick up on the signs and symptoms of someone who has experienced some energy deficiencies. And it used to be that we would use BMI as the screening tool, and which, I mean, of course, that makes some sense. And so someone who had a BMI below 19, but I mean, that is very lean. That is a very lean individual. And let's go to the other, our pathological kind of our clinical entity of this, someone who has a true eating disorder. Only about 7% of those individuals who have an eating disorder have a low BMI, have a BMI below 20. So using BMI as a screening tool and saying, oh, that person's body mass is just fine, and they don't have energy deficiency issues is not it's a very blunt instrument, and it doesn't work very well. And you're going to miss the vast majority of people that are having some sort of energy deficiency issues. We know that if you exercise for 12 hours or more per week, it's really darn hard to hit the overall caloric demands of the activity. And so PTs and podiatrists should be very comfortable asking questions of patients to make sure that, say, hey, like, talk to me about how much you're exercising per week. And if you're hearing 12 hours per week or more, if they've had a previous bone stress injury, so if they've had more than 2 low risk bone stress injuries, or they've had 1 high risk bone stress injury. So if you've had a navicular bone stress injury or second metatarsal or anterior cortex tibial bone stress injury or so forth, you should have like your spidey sense should start going off. Hey, this is someone that we probably need to pay a little bit extra attention to. Other patients, of course, if there's any sort of menstrual disruption, that's your canary in the coal mine, that this person's physiology is not adequate to support their overall endocrine health. And of course, that's what's driving our bone adaptation. So I think those things are all really important. I think I'm going a little bit from memory, but the other ones, I think there are some other ones too, is, for me, I talked a lot to patients about gastric distress. I think this is a really important, really often missed one.
Yeah.
The big one about that. Yeah, the big one, I asked them, like, do you ever have any gastric issues when you run or exercise? And there are 2 different reasons for that. One is that if someone has some gastric distress, they often might get a little bit fearful about that, and then they won't fuel adequately before the run, or they might not be able to fuel adequately after. So there's that direct effect. But the other thing too is that our digestive system is very energy intensive as well. It takes a lot of energy to digest food. And so if you're not consuming enough calories to fuel your exercise or what have you, you're also not going to have enough calories coming in to fuel like your digestive system. And so your gastric motility will go down. You'll start having a lot of GI distress, and so forth. So those are all like really important signs that I think a lot of times we as runners, we call them like, I don't know, like, runners like boo-boo belly or whatever. But I think those things are really important for us to be paying close attention to. So, and anyway, so there are those. We kind of got off on energy deficiency stuff, but I think that, again, I think those things are really important. I think anybody who we'll take a step back and go back to mechanical loading, because of course you're not going to get a bone stress injury unless there's some mechanical loading that's being applied to the skeletal system. So we know that certain types of loads are going to be a little bit more hazardous for a bone. a lot of times we kind of think of the high mileage runner as being someone who might be at greater risk. And that actually has more to do with the fact that they're burning a lot of calories. So we basically have two different ends of the spectrum. We have the high volume runner who is going to be burning a lot of energy, and that's going to be much more perhaps of a Red-S kind of issue. Then on the other end, if you start doing a lot of high magnitude type loads, so sprinting, for instance, sprint jumping for the jumping athlete, so basketball players and volleyball players and so forth.
Yeah.
Running uphill, we used to think that running uphill is actually going to be very low loads on a bone, but because when you run uphill, your calf forces, your plantar flexor forces go up quite a bit. That's going to really increase your bone strain. So those types of loads, we know that for every 10% increase in bone magnitude, or magnitude of loading, so for every 10% of magnitude of loading increase, we see a 50% reduction in the number of loading cycles before we start getting failure of the cortical bone. So that's really important. So it's an exponential relationship between speed work and bone microdamage accumulation. And the reason why it's really important is because we need to make sure that we're being very, very careful when we're prescribing our training loads, that we're not increasing the overall volume of training that they're doing as well. So once you start introducing speed work into an athlete's program, you need to draw down their overall running volume. And when you look at most half marathon programs or marathon programs, they're doing those things simultaneously. They're increasing volume at the same time that they're also increasing the amount of speed work. And it's not surprising that a lot of people get bone stress injuries leading up to a big marathon.
Yeah, and they happen, it's like the elite athletes as well. It's not just the recreational runners. It's some of the best athletes in the world are pulling out with injuries and bone stress injuries. And it still amazes me that it can still happen at that level.
Yeah, right. Well, in fact, for elite athletes, the main injuries they're going to get are going to be tendinopathies and bone stress injuries. They rarely get knee injuries. It's not an injury that they get. You tend to see a lot of foot and ankle bone stress injuries in that group, and you see a lot of foot and ankle tendinopathies as well. And yeah, I mean, I think that you have an athlete, and those cases they are running a lot of volume. Their year-round running is very high as well, and we can talk about that in a second as well. Why that's thought to be a risk factor. And then you start throwing on these very high volume workout or interval workouts where they're running very fast. And so they're running very, very fast. And so the loads on the bone are very high. And so that magnitude increases. And so their rate of or risk of accumulating microdamage goes up considerably. The flip side is also very true. And I think it's really important to think about these things. Again, it's going back to load. It's not good or bad. But if you increase load or loading magnitude by 10%, you reduce the number of loading cycles in half that the actual bone can tolerate. But if you reduce loading magnitude by 10%, you increase the number of loading cycles that bone can tolerate by 50%. So it goes both ways. And that's why even small reductions in loading magnitude per step go a really long way to reducing one's risk of developing a bone stress injury. So for instance, on your easy runs, run easy. Don't run run. What I mean by that is run slow, because that loading is going to be very low per step, and it's going to reduce your risk of accumulating microdamage. Other things you can do too. I think this is where shoe wear is really, or foot or shoes are really important. I think that running in the right type of shoe, I think is important. I think running in a racing flat or a minimalist shoe all the time, I think is not a good idea, because the overall plantar flexor forces end up being quite high. So I think rotating your shoes and into a shoe that is going to be maybe a higher drop shoe makes a lot of sense, because that's going to reduce your metatarsal and your tibial bone bending forces as well.
Nice. So when people ask why I'm running so slow on my Strava, I can just say, I'm just reducing my risk of a bone stress injury. Don't judge me.
That's right.
So talk us through the typical journey of someone with a bone stress injury that might walk into your clinic. Let's say they've got a
tibial. That's the most common one.
Tibia. We better go tibia. It's most common. Yeah.
Yeah, sure. Yeah, I can talk about those. So let's say it's a posterior medial tibial bone stress injury. We know that 90% of those occur in the middle or the distal portion of your tibia. So we only get a few in the proximal portion of your tibia. Once you get down there, when you start looking at diagnosing someone, one of the best things you could do is a hop test. And so have them hop 10 times so you can see if you can reproduce the pain. We know that, and then immediately you jump in there and you try to figure out like that zone of bone tenderness. And if that zone is more than 5 centimeters, you can start feeling pretty comfortable that this is going to be medial tibial stress syndrome, which is a different entity than an actual tibial bone stress injury. Once it starts getting below 5%, then you really need to start considering a tibial bone stress injury. And so then at that point, depends on the patient population. If you're going to send that person off to imaging, I think the default in the United States is to get imaging. I don't know if that's necessarily needed for everyone. I think that if you have a very, very focal bone tenderness, and it's in that distal, proximal or distal, put the posterior medial tibia, I think you can probably feel pretty comfortable that it's some degree of a tibial bone stress injury. If it's on the anterior cortex, where they've got their tenderness, you really need to send them off for imaging because that's a high risk area. And those get missed for a very long time too. Those get missed on average of 5.5 months. But I think from there, the imaging thing, I think where a lot of clinicians will go wrong, and I know we're just talking about the initial screening part of it, is that they might do something like use a tuning fork. I don't know if that's very prevalent in Australia, and it's something that you see a lot in some medical settings here in the United States where they don't have access to imaging. And I'm thinking about like some sideline, like athletic training will do this a lot, or some physical therapists that are working on the sidelines of certain sports, like in the athletic training room. They may use like a